Let's talk a little bit about postpartum adaptations. What adjustments characterize the postpartum period? Compared to the excitement of labor and delivery, the postpartum period, the 6 weeks following delivery, might seem to be a time of relative calm and quiet restoration. The mother's reproductive system is gradually returning to its pre-pregnancy state, while the newborn is integrated into the family unit. However, this fourth trimester is not without its unique nursing challenges. Not only are the profound physiologic changes taking place in almost every body system, each with the potential complications, but your postpartum client's response to her newborn during this time is also influenced by many factors. These include her energy level and comfort, the infant's condition, and the existing family dynamics. During this time of disequilibrium, the care and support she receives from you and the rest of the healthcare team can make a tremendous difference in her overall adjustment to her new family structure. What changes can you expect to see in the reproductive system? First, we'll review the changes that take place in the reproductive system after delivery. The uterus undergoes a process called involution, a reduction in size and weight that eventually restores it to its pre-pregnancy state. There are variations, of course, but generally the uterine fundus is just about at the level of the umbilicus immediately after delivery. By 12 hours after delivery, it can be palpated about 1 centimeter below the umbilicus. During the next few days, it descends 1 to 2 centimeters a day, and by the 9th or 10th day, it has completely descended into the true pelvis and can no longer be palpated. When assessing your postpartum client, locate the fundus and check its firmness. A soft, spongy, or boggy uterus is a sign of uterine atony and a potential complication of postpartum hemorrhage, and fundal massage is indicated. If the fundus is higher than normal and displaced to the right, suspect a full bladder. This can interfere with the uterine contractions and contribute to uterine atony and excessive bleeding. After vaginal delivery, the cervix is typically edematous and bruised and may also be lacerated. If lacerations are large, the client might have a continuous seepage of blood, a trickle of blood that is different from the usual postpartum bleeding. If the laceration is severe, it might have to be sutured, and cervical edema can persist for as long as 3 to 4 months. Nevertheless, the cervix gradually closes during the postpartum period, with the internal os completely closing within 2 weeks. However, the external os doesn't return completely to its pre-pregnancy state, remaining slit-like in appearance instead of round. The vagina and the perineum might also be bruised and swollen. You might see a sutured episiotomy, which is an incision made into the perineum to prevent tearing during delivery. Over time, your client's hormones will revert to non-pregnant levels, with estrogen levels returning to normal by 10 weeks. Although it is highly variable, non-lactating women ovulate an average of 10 weeks after delivery, while lactating women ovulate an average of 17 weeks after delivery, provided they lactate for 3 months. It is important to teach clients they cannot rely on breastfeeding as a method of contraception. This too is highly variable among women. After pains or tonic uterine contractions occur with varying intensity as the uterus attempts to expel clots and placental fragments. In primiparas, the uterus tends to stay in a better state of contraction. Thus, multiparas usually find their periodic, intense contractions more painful and often require analgesics to relieve the pain. As prescribed, administer analgesics such as ibuprofen for mild to moderate discomfort, or acetaminophen with codeine for severe pain. Clients who are breastfeeding will also experience more intense contractions, triggered by the oxytocin that is released as the infant sucks. The uterine discharge of blood, mucus, and tissue after delivery is called lochia. It changes in color over time. Lochia rubra is bright red, bleeding for 2 to 3 days after delivery. Lochia serosa is pink or brownish watery discharge, seen from 3 to 10 days after delivery. And Lochia alba is a yellowish-white discharge that can persist for as long as 6 weeks, but is usually seen from the 10th to the 17th day postpartum. Make sure you assess the lochia for amount, type, and consistency. Lochia has a musty, stale odor, but is not offensive. If you detect an offensive odor, it might be a sign of a uterine infection. Another significant change is the breasts. They begin secreting colostrum during pregnancy and continue after delivery. The breasts become engorged with milk between 2 to 4 days after delivery. Lactation suppression measures are helpful for postpartum clients who are not planning to breastfeed. Advise them to avoid stimulating the breasts or manually expressing milk from them, as this will only promote milk production. Wearing a tight-fitting bra, applying ice packs, and taking acetaminophen may help with the discomfort until the milk production ceases. After delivery, plasma volume decreases as the excess fluid accumulated during pregnancy is eliminated. In addition to diaphoresis, diaphoresis helps eliminate fluid through the skin, so heavy perspiration is to be expected for the first few days after delivery. It is common at night and can be disconcerting, so be sure to prepare your client for this phenomenon. Cardiac output and stroke volume return to pre-pregnancy levels by the 3rd postpartum week. Hemodilution immediately after delivery is followed by an increase in hematocrit that returns to normal by 4 to 5 weeks. Your client's white blood cell count will be elevated for the first 10 to 12 days, but returns to normal soon afterwards. Clotting factors are increased early in the postpartum period, which contributes to a greater risk of thromboembolism, but they return to normal by the 3rd week. Meanwhile, pulmonary function remains altered during the postpartum period, but returns to pre-pregnancy levels within 6 months. After delivery, the tissues around the urethra are swollen and bruised. As a result, your postpartum client is likely to have decreased sensitivity to bladder filling pressures. This can cause problems with voiding. Some clients are unable to void and might even have to be catheterized. In the first 12 to 24 hours after delivery, it is typical to experience profound diuresis, excreting as much as 2,000 to 3,000 milliliters of urine. It is not unusual to see blood in the urine due to bladder trauma. By 6 weeks, normal renal function returns. As fluid balance is restored, your client will lose weight, an additional 5 pounds, or 2.3 kilograms, over the 10 to 12 pounds, or 5 kilograms, she loses with the baby, placenta, and amniotic fluid she is no longer carrying. By 6 to 12 weeks after delivery, almost all women lose 25 to 35 pounds, that is about 11 to 13 kilograms. A few hours after delivery, most postpartum clients are hungry and thirsty. They've expended tremendous energy during labor. Plus, they've had fluid and food restrictions. They are now experiencing diuresis. Your client, postpartum, can resume a regular diet. However, her intestinal motility may not be up to par just yet, and fear of having a bowel movement with a fresh episiotomy or swollen hemorrhoids might make matters even worse. Administer a stool softener as prescribed to encourage elimination without strain, and assure her that normal bowel function usually returns by the end of the first week. Typically, vital signs do not change much during the postpartum period. You might see your client's temperature rise slightly during the first 24 hours due to dehydration. Her pulse could be a little slower than usual for as long as 10 days, but will gradually return to pre-pregnancy baseline. Respiratory rate and blood pressure are usually normal, but orthostatic hypotension is possible during the first 48 hours. What diagnostic tests are usually done in the postpartum period? To supplement your postpartum assessment and screen for hematologic signs of infection, a complete blood count is usually done. Hematocrit and hemoglobin will indicate whether or not the client is anemic. An antibody screen will determine the mother's rubella immunity status, and if she is not immune, she will need a rubella vaccine prior to discharge. Instruct her not to become pregnant for 3 months to make sure that the vaccine does not have an adverse effect on her next pregnancy. To summarize then, Your ongoing assessment of your postpartum client includes vital signs, lochia, fundal height and firmness, bowel and bladder function, perineal healing, breast condition, teaching needs, and comfort level, all assessed at frequent intervals. Now let's try a critical thinking exercise. CJ gave birth to her baby at 8 a.m. Your assessment findings 12 hours after delivery are as follows: blood pressure 120/80, pulse 70, respiration 16, temperature 99.5 degrees Fahrenheit, that's 37.5 degrees Celsius. Uterine fundus 2 centimeters above the umbilicus and to the right of the midline, and breast soft. CJ says that she has been perspiring a lot and that she has just breastfed her baby. She asks, how much milk do you think he got? First, list the assessment data that would give you a reason to explore further for complications. Temperature 99.5 degrees Fahrenheit, or 37.5 degrees Celsius. Uterine fundus 2 centimeters above the umbilicus and to the right of the midline. And CJ's concern about how much milk her newborn is ingested. Now consider this question. What is the probable cause of the slightly elevated temperature? The client's temperature is not high enough to indicate an infection, but it cannot completely be ruled out. A slightly elevated temperature is not unusual in the early postpartum period and might just be a result of increased metabolism from the work of labor and delivery, not to mention dehydration. Another question, if you were to investigate further: what information do you need? You need information about CJ's hydration status, her skin turgor, and her intake and output. You should also investigate any signs of infection, such as difficulty voiding, pain with urination, and the Rita score of the episiotomy. That's redness, edema, ecchymosis, discharge, and approximation. CJ may have an unrelated illness, such as an upper respiratory infection. That would explain the slightly elevated temperature. Yet another question. When you find the fundus firm but 2 centimeters above the umbilicus and to the right of the midline, what other assessments should you make? The fundus at the time of palpation should be at midline and just below the umbilicus. Because the fundus is not in this location and is above and to the right of the midline, you should suspect a full bladder. Typically, with a full bladder, you can feel a bulge above the symphysis pubis. Ask CJ how long it had been since she had last voided and if she feels uncomfortable, as if she needs to empty her bladder completely. You should inspect CJ's perineal pad to determine whether or not lochia is excessive. Also, be sure to evaluate the firmness of the fundus. And finally, how will you answer your client's question? Explain to CJ that she will not be able to determine the actual amount her baby takes in at each feeding, as she would with a bottle of formula, but that she will become attuned to other signs that her baby seems satisfied, like remaining quietly alert or sleeping after the feeding and urinating sufficiently. She need not be overly concerned right now, because it will take a few days to establish a good milk supply. However, it is important for her baby to nurse regularly at this time to stimulate milk production. Besides, the breasts do produce colostrum at this time, which contains antibodies, protein, and fat-soluble vitamins that will nourish the baby in the meantime. Which therapeutic nursing interventions will you offer your postpartum client? During the immediate postpartum period, your client might develop chills as a result of various vasomotor and neurologic responses. Comfort her and offer her warm blankets and warm beverages. Also provide fluid and food to help replenish the energy stores she has used during labor and delivery. If your client's fundus is soft or boggy, assess for a full bladder and determine whether or not she is voided. Then gently massage the fundus. If she cannot void, assess for urinary retention and bladder distension. If she is retaining urine, catheterize her as ordered. Most hospitals have standing orders for postpartum clients, so you can probably assess and proceed to catheterize.